I wanted to talk about strengthening health systems and actually learning from the Ebola outbreak. And just as a caveat, I'm going to focus mostly on strengthening health systems at the national level and below, as opposed to the international architecture around health systems. And most of my experience is really around Liberia and with our team work also in DR Congo. So that's where the basis for some of this. But Liberia has probably had the worst in terms of the trajectory of the epidemic and then in terms of the turnaround. So I think that there's lots of good lessons from that. Stop me as I go along if there's anything that's unclear, but hopefully I'll finish with enough time. I plan to finish with enough time for discussion. So obviously we know the West Africa epidemics really as a viral disease epidemic that of course you see the huge number of cases and deaths as well, over 10,000 deaths that occurred during this time period. But clearly it was also an epidemic of fear and distrust. And it's also important to put it in context of what this looks like in terms of an epidemic and how it affects different systems. And looking at it, you see a lot of these spirals or vicious cycles that occur with Ebola really stimulating a number of them. So one of them is around the health system that was already weak to begin with, that put increased stress on it, that led to worsening of health conditions and further weakening of health infrastructure, damaging the health workforce, further demotivation, lots of death among health workers, and further closed clinics, and leading to a downward spiral in the health system. Related to that is a downward spiral around social capital, with the inability to deliver services leading to even further loss of trust in government and public services, and was already pretty low trust environment, and really threatening community cohesion and culture at one level. And then having a similar type of related effect on livelihoods and the economy, with clear impact on the labor force, agricultural productivity, and trade and income, and these cycles feeding on each other, but really with a single shock. One of the things that we were told early on was to look at, what was the impact of this. So the Centers for Disease Control had a famous model early on that from 2 countries alone, we're going to have, one was projected to have up to 1.4 million cases. That's corrected for underreporting that was there. So, and produced these models that then showed if you intervened early with hospital beds, ETUs, Ebola treatment units, and you could get hospital rates up, you could still have some kind of impact on the epidemic. It mattered when you started, but just so you know, these are cases per day. So these were that they were projecting to start. And so the latest one was in terms of starting November 22nd. And having this progressive increase in hospitalization and what the impact was. So this really focused attention early, or one of the things, there are other things as well, on building ETUs and getting people into treatment early. There were other models as well that I'll come to. So I wanted to talk a bit about the lessons that we can and should learn. So one of them is to look at some lessons that we should have known before the epidemic, then look at some lessons during the epidemic and as it's winding down, hopefully, and then what the implications are for health system strengthening. So one of the lessons that should have been learned really was from smallpox control, another very scary viral disease. And this is lessons that D.A. Henderson was advising to the Ministry of Health in Liberia, to other partners, and to those of us who would listen. He was a WHO director of smallpox eradication during the time. And he basically said that that international response should not be the focus of the response. It really should be about supporting national and local leadership to carry out plans and not to displace it, and highlighting the critical importance of working with communities in order to achieve isolation of cases and a high probability of case finding. He also said that in terms of management, how do you address these things, really critical to communicate rapidly, systematically, using routine line listing data, and to have this kind of daily or twice daily types of communication between field site center within a country in order to share learning and experience. And so this was some of the key lessons that he was communicating early on. I'll leave it to you to see how much of that actually happened or when it happened. Another lesson should have been learned from DR Congo, who had 6 previous Ebola outbreak epidemics and actually had a 7th one during this time as well. Here's the health minister. And we went to Congo, were asked by UNICEF to try and pull the lessons that they learned together. And what they responded was that really you needed a rapid response. Okay, no surprise there. But the key was around community engagement in order to gain trust, and really advised against parachuting people in from anywhere that will scare people, with or without the kind of spacesuits that they wear. And also the importance of having an integrated community-based containment and care strategy. Now, granted, all of their intervention, all of their outbreaks occurred in rural or small towns, so it was a little bit different. But they had, from his perspective, what they had seen was, this is literally, translating from French, from Dr. Kabange, was again these set of vicious cycles of Ebola, where you look at it, one perspective is from an epidemiologic perspective of where transmission occurs in community hospital and burial, and really having problems with both how you transmit infection at each of these sites, but the human behavioral component, what he called it, that underlies it. The disempowerment and invasive approach that was reinforcing fear, stigmatization of survivors, leading to inability to identify contacts and multiple contacts, the poor inpatient care and communication between hospital providers and communities, leading to really inadequate quality of care and also distrust, increased exposure within the health facilities, and of course even worse at the burial with considered inhumane and sometimes violent responses to some of the attempts at burial. And he said the key is really to try and create this virtuous cycle where communities own the fight and you reintegrate survivors, you try to promote quality of care, responsive care with dignified death and safe, dignified burial in order to reduce the epidemiologic types of exposures in all 3 of the areas, community, hospital, and burial. And one of the things that we were trying to broker, one of the reasons we came to DRC was because they had actually offered to bring 1,000 health workers in a team approach. It was not really taken up. Well, a couple of teams ended up going to Mali, but it had some difficulties in all the other countries, which is a different discussion. But what was unique to them was that they actually proposed a modular, integrated type of response with a multidisciplinary team, with not just clinicians and outreach and safe burial, but with a lot of anthropologists, as they called them, with logisticians and with lab, to be able to act in an empowered way in a particular population in a defined area, where you combine the community outreach services with a hospital, lab, and burial in a coherent way with trained and paid health workers, and actually paying community members to do work. And you do this for, in their view, 3 to 4 months, and you can actually manage this at least in rural areas. Whether this was the urban response was a little bit different, but they were prepared to send 1,000 health workers. So that's what we should have known before the epidemic. What did we learn during it? I think we did do a lot of learning. This again taken from Liberia. We're showing here are the epidemic curve in 4 counties. Montserrado is Monrovia, where the city is. Lofa was the first affected county. And what you see here was the increase, and the first sort of change in the curve happening in September. Now, originally in Lofa County, there was lots of denial and distrust, hiding of patients. And by September, what they had learned was that they needed active and extensive community mobilization to do, and they started problem solving on their own, creating different kinds of community care centers to manage cases, to hold cases, to basically reduce the risks of exposure at different points. It wasn't great medical care, to be perfectly honest, but it was trying to find ways to reduce things, reduce exposures primarily, and to produce or provide some dignity to patients. There was a lot of innovation. Here's some examples from the incident management teams, different ways in which locals had built ways of hand washing here at different sites with chlorinated water. So that was some of the learning that was happening on their own, not from the outside. That was sort of going on really from the bottom up. If we ask what actually turned around the epidemic in Liberia, there have been some claims. So in the New England Journal article, it was a lot of credit was given to UNMIR, which was actually initiated in October, and for bringing in lots of ETU beds, patient isolation, and safe burial. The Lancet had some papers that basically, again, pointing to the key role of Ebola treatment units for building and staffing the units. So before looking at whether this is true or the degree to which it's true, we should have some understanding of what does it mean to turn an epidemic around. So I'm going to use one frame of an epidemiologic notion around the reproduction number, which is a technical term for the average number of cases that one single case produces during their infectious time period. And so, you can look at it, is it rising, is it falling? The thresholds you might look at as if it's greater than 1, that means the epidemic is growing. If it's less than 1, it's declining. And if it's 0, the epidemic is over. So I'm showing you here the reproduction number of Liberia nationally over time with confidence intervals on this axis, and again, 1 is sort of the critical point. And this is just trying to put a timeline for the main Ebola treatment units, starting with the first isolation, and then Foya is in Lofa County, Elwa is in Monrovia, and relatively few beds. And what you see is this, they actually had lower in May and then came back with a vengeance in June, July. Another big resurgence in August. This is actually when they put the quarantine on and had the riots. And here, by late September, well, I should say before that, this is also the date that they reorganized the IMS and put Tolbert and Answan in charge, and they totally reorganized the system. And since then, there was a decline and pricing in the last week of September and continuing to go down, some variations after that. Most of the beds actually come in, they were announced in October or September. They really came in late November, December, and even in January they were still building beds. So what turned it around? It was probably not the ETU beds. There were very few available early on when they were most needed, when they were overfilled and you couldn't find beds. But most of the beds were built after the reproduction number was below 1. And in fact, most of the beds built were never used. A lot of empty beds in Liberia that were closed. Was it better hospital treatment? Maybe, but most cases never made it to the hospital when it was going down and when it was below. Was it UNMIR? I think that would be a huge stretch, because by the time they started, it was already below 1. The curve was reduced much earlier when the incident management system was reorganized. So I think that's not really incredible. I'm not saying they don't contribute, but it's hardly likely the primary region. Was it the forced quarantine? Because that's right when it started turning around. Probably not. It really heightened distrust, resistance, and actually had riots in West Point. But what it did do was it created a reason to learn very quickly. It prompted government to change its tactics, and at this point, not only did they have a different team, but they really started working on community engagement and communication strategies, not just about where to put beds, but about how do you get them involved with safe funerals, how do you get them involved with case finding, isolation, and in care. So what did turn it around? Obviously, I'm pointing towards the role of engaged communities, where they've moved really from resistance to one of ownership and participation. The other thing I would point out is that there are really a lot of local epidemics. It didn't make much sense to continue looking at it nationally. And what this is aggregated at county level, where we see the reproduction numbers over time, starting at different points and going up and down. But what it implies is that you actually needed these kind of local responses in each of these areas around the country. And as we'll come to later, they actually behaved differently in different communities. Clearly, behavior changes had occurred. It's not quite clear which behaviors mattered most, whether it was the isolation of sick cases at home and at clinics, whether it was the general hand washing campaigns and no touching, whether it was about safe care at home, or it was about the case finding. Clearly there was an expansion of the safe burial, which is both the safe burial teams but also safer funerals and larger acceptance of having safer funerals, at least in Liberia that I can think that is the case. And the last point I would make is that it really is about strong national and local leadership. And I would point out that over 90%, I think it's closer to 95% of the workforce was local, and most of the deaths, almost all the deaths are in locals as well. This man deserves a lot of credit. He took over in mid-August. He's the one who organized the response, put them into teams, put people on task. He communicated frequently internationally, and you probably heard him on the BBC a lot, actually, and was constantly changing the strategy based on data of various kinds. And he clearly set a tone of optimism and purpose that was very important during a time of really fear and distrust. What should we learning from this? Well, where have all the flowers gone? That's a little older than me, but the chorus line is, when will they ever learn? When will they ever learn? And I'm not going to sing it for you because then, you'll leave. But I think one of the things we should learn is that, we're talking about a resilient health system, but what does that really mean? I think it's what stopped the epidemic was really about engaged communities. Doing it early would have been better, but about building trust and ownership. About these integrated community-based outreach, case finding, clinical care and hygiene, not on their own, using data routinely and sharing it, getting actors to communicate, and again, depending on national and local leadership. So what are the implications for health system strengthening? I think a lot of people are thinking about investments in infrastructure, training, drugs, vaccines, surveillance, and information technology. All of these are good things. Largely, these are not the things, arguably surveillance would be different, but these are not the things that actually turned the epidemic around. I think they are important, and they certainly would have prevented things, would have been better with the early response, but it's not just about investment in these inputs and these building blocks. It really did depend on this engagement, behavior change, using stakeholders and using information. And I would argue that, or plead really, that these are elements that should not be forgotten as we work, hopefully together, in rebuilding health systems. It's about keeping the public in public health, as I would argue. It's about supporting community engagement. It's not just building and training. It is about supporting national leadership and plans for comprehensive response, not a UN coordination or donor-led response. It's about building better systems for accountability and use of data. It's not about building another information system or standalone surveillance, which tends to be the response. It clearly is about disaster preparedness and response, but integrating it into public health and public systems. And there is a research and learning agenda. I think I've spoken fast enough that I can talk about this, because I think there's important research and learning agenda that should be there, not only from this, but from the next epidemic or next public health crisis that's important. There is a big basic science and clinical research agenda that is unanswered. We can answer some of them. Things around protective immunity, who was protected, who was not, how long will that immunity last for among survivors? Obviously, we need more work around vaccines, therapies, diagnostics, and even the progression of disease and survival. There was a huge missed opportunity to test clinical protocols. Would have been hugely difficult in a distrustful environment, but could have been done. It's something we need to prepare for the future. We did not really have good protocol. There's still disagreements over even things like hydration among kids, among anti-motility, among how do you handle agitation in these settings. So there is a huge clinical agenda that still has not really been addressed. And I would suggest that this is systematic. There are things specific to Ebola, but it's a systematic issue about infectious disease epidemics, but probably all public health emergencies. I'm more inclined to look at the health systems research agenda. There's a big issue, I think, around the collateral damage. How do you identify and prevent it? The unimmunized children, some of the projections have been to larger deaths in kids because they haven't been immunized just due to measles than from Ebola. But there's issues around stigmatization and the depleted health workforce, how to respond, prevent, identify and respond to emergencies. How to better interrupt EVD epidemic transmission, which I think is, again, generalizable to other things, better understanding of these risk factors. And I think a big thing is developing better models of epidemic transmission and the effects on health systems, but even just the effects on the epidemic, I think, is sorely needed. I'm not going to go into these in details, but this is what one of my grad students did from the line listing data for 3 countries. This is all we know about the chains of transmission of everyone in the line listings up until the end of the year. So it's not current, and you can see some details up here. But one thing that I think stands out is that these things should all be connected to each other. They started from one source, which you see is mostly white spaces. So we don't know a lot about how these came together. And if we can find some of these, even among this, if we can find the types of transmission, the factors, and bridging events, that would help a lot. Obviously, it would have been a lot more helpful in real time to be able to respond to these things. But we need to build the better surveillance to be able to address these. The other thing I was referring to about these local epidemics. So what we've done here, or in the process of, well, this is what we've done is each line represents a sub-county, sub-district, or sub-prefecture in the 3 countries, and the reproduction number over time. And we started them from the second case, so we've converted them not to one point in starting time 0. And what you see here is that the communities really behave very differently in terms of their in terms of the reproduction number, and we need to find out why. It turns out there's a group of communities that respond very similar, but most of them are quite different. Multiple peaks, different slopes, and different durations. And we really need to find out more about how that works, that we can better prevent and identify in the future. We need better models. There's a CDC model. There's another WHO model that they used pretty well at the same time. They're a little more conservative because they didn't go out very far, and they based it largely on following past performance trajectories. But they did not work very well for most model purposes. They don't account for behavior change and adaptation. They're fixed models. They presume complete mixing and exposure. They don't actually work in terms of time and space, and they have fixed growth relationships, and they're terrible actually at trying to identify, predict, or model how do you actually change that curve. At this point, I mean, here's an attempt in this model, but basically they're not very useful for many purposes. They were useful in showing, sort of relative impacts of types of interventions and scaring people, clearly. There was actually a model, if you added all the countries, including Guinea, it could have been 3.5 million at one point. Thankfully, they didn't publish that model. So I think that the consequence of these poor models was about focusing attention on ETUs and getting people into treatment. These are not bad things, but it deflected attention from what was really needed most, which are things that they can't model, which is about engaging communities in behavior change, about what actually happens with isolation at different levels, and about case finding. And the other thing is it perpetuates this mental model of a health system that is based on inputs into a system. So we're working on a different kind of model in Liberia, and hopefully we'll be able to extend it. Basically an agent-based model where you basically have the agents are actually the individuals. We can put all 6 million people in Liberia and model where they live. You have a number of states from susceptible, exposed to, dead and buried, and dead and alive. And so a model is then built literally on the population density in the geographic space that they actually live. And we create this create an agent-based model where you can then give different initial parameters of where it starts, different the population densities, different conditions about the virus itself, and then working on interventions such as case fatality rate, probability of detection, probability of getting into care, different kinds of isolation at these different compartments of community, etc., and then model what happens to the susceptible, exposed, and deaths. So this is a particular run where you can see each of these dots as a group of agents. It's not, you can break it down to individuals and get sort of the different parameters that occur. So basically we're trying to give a different kind of model that we hope would be useful in the future. We'd like to extend this to other health system effects. if not other diseases, other services, and make them broader. But I think that this kind of modeling offers a whole lot of new probabilities. And just by the way, this is not my work. This is work of Josh Epstein, Erez Hatton, and his team at the Center for Advanced Modeling. These people are much more numerate than me, so I can't do that. But I think it does offer lots of opportunities. But bringing us even more back down to the ground of what matters. Models will help a lot, but just to remind ourselves that there really were a lot of frontline heroes, and that being able to support national and local leadership would be the message I would like to end with. This is Francis Kate who was talking, in this case, talking to a local crowd, but we are neighbors, community leaders, and global citizens uniting for a common good, and with you we can accomplish even more. And I hope we can do that as we rebuild health systems in the future. So thanks very much.
Thank you.